So T wave in ECG. This is my topic of the talk. So it is difficult to interpret separately T wave separately, as because ST segment and T wave in most of the pathologies move simultaneously. And beginning of the T wave is not sharp, as because you see the ending of the ST segment and beginning of the T wave in most of the situation is not sharp. It is just approximation that this is the beginning of the T and this is the end of the ST segment. So this is another problem. So this is a reason why difficult to interpret. And both are part of the repolarization. Both the ST segment and T waves are part of the repolarization of the cardiac action potential. So this is the reason it is difficult to interpret or comment about the T waves separately. And again, T wave is one of the very important component of the action potential, that is the ECG, electrophysiological concept of the ECG, is because T wave marks the junction between the ventricular systole and diastole, as because the ventricular systole is the QT interval, that is from the beginning of the Q and the end of the T. So T wave marks the end of the systole, and simultaneously T wave also marks the junction between the absolute refractory period and relative refractory period. You see, from the tip of the T, if we draw a perpendicular line, the left part is absolute refractory period and the right part is the relative refractory period. So this is the reason it is difficult to interpret T wave separately, but still we have to learn something about the T wave. There are some information about the T waves, normal T waves, as because the T waves, normally the T waves follows the direction of the QRS complex, the same direction. The dominant component of the QRS complex moves in which direction the T waves move. So as for example, you can see in the lead 2, the QRS is upright, so T wave is upright. In AVR, the QRS complex is downward, so T wave is downward. So this is the basic concept, that is that T wave follows the direction of the QRS complex. And also T wave is physiologically and normally is negative in AVR. You see, this is the AVR and V1. AVR and V1, but this formula is not applicable in case of the bundle branch block. And the T wave amplitude, it should be less than 15 millimeter in precordial leads from V1 to V6 and should be less than 5 millimeter in limb leads. And the normally the T wave is asymmetric. This is the normal. Asymmetry is the normal criteria of the T wave. You see, this is the blue mark, that is the perpendicular line here. You can compare the left side and the right side of the T wave, and you can see the left segment and the right segment are not similar, So this is the criteria of the asymmetry. So asymmetry is the normal criteria of the T wave. So these are the some information about the normal physiology of the T wave. And we should always remember this golden rule of impulse propagation. We know the golden rule of impulse propagation is that from an electrode, the impulse going away produces the negative deflection. As for example, you can see in this figure, this impulse is going away from this electrode, so there will be negative deflection, and it is going toward this electrode, so there will be positive deflection. This is the golden rule of ECG. So we should always remember this will be also applicable in case of the T wave. So toward the lead, positive deflection, away from the lead, negative deflection, and perpendicular to the lead. As for example, you can see from this figure, that is the perpendicular of the lead, that is there will be biphasic. So depending on the amount of the perpendicularity, so there will be the positive and negative deflection comparison. So this is the normal criteria of the electrical propagation of impulses in relation to a position of the electrode. Away from the electrode, negative, towards the electrode, positive, perpendicular to the electrode, it should be the biphasic. But in case of the T wave, QRS is the depolarization and T wave is the repolarization. So the movement should be opposite. That is, the T wave should move opposite to the direction of the repolarization. That is the depolarization. That is, it should be ideally the T wave should be in opposite direction of the QRS complex. It should be. it should be the opposite direction of the QRS complex, as because QRS represents the depolarization and T represents the repolarization, and direction of the both components are opposite. That is, the depolarization and repolarization moves in opposite direction. So T wave should be in opposite direction, but in the same direction. Why? Why both the T wave and QRS complex move in the same direction? This is one of the example you can see. This is one of the figure that is on the left side. You can see this is the Purkinje protein, that is the Purkinje fiber. The predominant Purkinje fibers lies subendocardially. So depolarization of the myocardium starts from the endocardium, and the depolarization movements goes from endocardium to epicardium. That is from endocardium to epicardium in this direction. And usually the electrodes are placed over the endocardium with the chest wall. So depolarization is the movement of the positive. This is the positive pole of action potential. This is the positive pole. So depolarization movement means movement of the positive pole towards an electrode. So there will be some positive deflection. So depolarization produces positive deflection. That the same electrode, because of the increased intraventricular pressure, the repolarization should start from the, instead of starting from the endocardium, the repolarization again starts from the epicardium. There is movement of the repolarization from epicardium towards the endocardium. And in case of the depolarization, endocardium to epicardium. In case of repolarization, epicardium to endocardium. And this is the negative pole. That is movement of the negative pole of the action potential. So it can be assumed that negative wave traveling away is almost equal to the positive pole moving towards an electrode. That is, it is equivalent. That is, negative pole going away from this electrode means positive pole is coming toward this electrode. So the repolarization again produces the positive deflection. That is, this is the region. Both the depolarization and repolarization moves in the same direction. This is the basic concepts of ECG and electrophysiology. So this is the region why both the T wave and QRS complex move in the same direction. This is physiologically, this is the normal physiology. And these are some examples of the abnormalities of the T wave. This is the normal T wave. This is the normal T wave, that is the asymmetric normal T wave, and less than 15 millimeter in case of the precordial lead, and less than 5 millimeter in case of the limb leads. This is the normal T wave, that is the asymmetric T wave. This is the normal T wave, but T wave may be the biphasic. This is biphasic. This is like this. This is the biphasic T wave. This is the bifid. This is the one tip and another tip. So this is the bifid T wave, and this is the tall peak T wave. Tall peak T wave, and this is the flat, prolonged, delayed T wave. This is the inverted T wave, and this is again inverted T wave. There are two types of inversion. So these are the examples of various abnormalities of the T wave. And in summary, the T wave abnormalities may be tall, biphasic, bifid, or flat. These are the abnormalities of the T wave. Some examples other than the normal physiology. I will give some example like this. These are the examples of the tall T wave. That is, the tall T wave means, definition criteria of the tall T wave means that is the 15 millimeter, 5 millimeter in case of the limb leads. The height of the T wave should be more than 5 millimeter in case of the limb leads, more than 15 millimeter in case of the precordial leads, 15 millimeter, or more than half of the preceding QRS amplitude. That is the more than 50% of the preceding QRS amplitude. So either of this criteria fulfill, that is the criteria of the tall T wave. So tall T waves, there are two examples of the tall T waves. That is the hyperkalemia, in case of the hyperacute ischemia. These are the two examples. So we can compare with the normal variant. This is the normal T wave. The height is less than 15 millimeters in case of the precordial lead, and asymmetric. Asymmetric, this is the one of the basic normal physiological criteria of the normal T wave. But in case of the abnormal T wave, you see symmetric. Both the left and right parts of the T wave from the starting from the peak, this similar. That is a symmetric T wave. Both in case of hyperkalemia and the hyperacute ischemia, the T waves are symmetric. But 3 points we should consider for differentiation between the hyperkalemia and hyperacute ischemia. That is the tip. Tip in case of the hyperkalemia is very pointed, sharp, like the needle. There is a very sharp pointed tip in case of the hyperkalemia. This is little rounded in case of the ischemia, little rounded in case of the ischemia. Then base is wider in case of the hyperacute ischemia. The base is narrower in case of the hyperkalemia. And symmetry, both are symmetrical, but comparing to the normal, it should be asymmetric in case of the normal. So these are the 3 points, that is the tip, base, and the symmetry. These 3 points should be considered for differentiation between the tall peak T wave in case of the hyperkalemia and the hyperacute ischemia. So tall peak T wave, there are 2 causes, hyperkalemia and hyperacute ischemia, and these are the points by which we can separate between these two. Some examples like this. This is one of the ECG examples. You can see the tall peak T wave. The tip is very sharp. You can see mid precordial leads, particularly the V2 to V5, V4 and V5. The T waves are very pointed and tall peak. There is a 5, 10, more than 15 millimeters amplitude. The tip is very pointed like the needle. The base is not wide, little narrower. So this can be a case of the hyperkalemia. That is the hyperkalemia. So always we have to consider the points, that is the company it keeps. That is this T wave, what are the other ECG findings it keeps in association with this finding. So we can consider, that is, in this ECG we cannot see the P waves, that is the absent of the P waves, and QRS complexes are wide and it does not fulfill the criteria of the right bundle branch block or the late bundle branch block. You can see the V6 does not fulfill the criteria of the late bundle branch block. So wider QRS complex does not fulfill the criteria neither for the RBB or the LBB. It is a case of the IVCD, intraventricular contraction defects. And simultaneously, the QT is prolonged. You can see from this, in any lead, you can see the QT is prolonged. This is the ending of the key. So the QT is more than 50%. That is from here to here, you can see this is more than 50% of the cardiac cycle. So QT is prolonged. So P is absent, QRS complex, that is IVCD, QT is prolonged. All these points indicate that this might be a case of the hyperkalemia, as because all these components may be present here, and QT prolongation may be because of the hypercalcemia as well as from the hyperkalemia. So this is the way how we can differentiate the types of the tall peak T wave comparing with the ischemia. So this is the case of the hyperkalemia, and maybe in case of the chronic renal failure, as because all this can be present in case of the chronic renal failure, that is the hyperkalemia as well as the hypercalcemia. So this is one of the way. This is another examples of the tall peak T wave. You can see the T wave is tall, that is the in case of the mid precordial leads, particularly from V2 to V5, the T waves are tall, and the tip is little rounded, the base is little wider. So this is a tall peak T wave definitely. But what is the cause? With the hyperkalemia or hyperacute ischemia. To differentiate it, we can take the help of the other findings, that is the company it keeps. We can see the T wave is positive in V1. What should not be? Actually, in case of the V, the T wave should be negative, but in here the T wave is positive. So this is another company along with these T wave findings. Then symmetry of the T waves, that is the T wave is symmetrical, so it should not be normal. This is abnormal as because the T wave is symmetrical. The upsloping ST depression in different leads. These are the upsloping ST depression in different leads. We can see it is present in the V2, V3, in different leads, inferior lead also, the lateral lead also, in different leads. That is the global types of the ST depression with concavity upwards. So this is the upsloping ST depression in different lead. ST elevation in AVR. You can see the ST elevation in AVR. So these are the associated finding in along with the tall peak T wave, and this associated finding match with the finds of the ischemia. So that is the ST depression, ST elevation, all can be present in case of the ischemia. So this is likely a case of the hyperacute ischemia. But the another special findings in this is that this hyperacute ischemia, in case of the tall peak T wave, the ST depression usually should be convex, that it should not be concave upward. So concave upward is there some mismatch finding in case of the tall picture. So this is a case of the acute coronary syndrome, but this is some inconsistent finding, and presence of such finding along with the presence of such hyper TF is a special variety, what is called the D Winters TF. So this is the hyperacute ischemia, that is hyperacute T waves, and special variety is the D Winters T wave. So we can think that the T wave is not symmetrical in case of the V4 and V5, but still these are the symmetrical. Actually, the height, that is length, is not important, as because this is the first part of the T wave in V4, and this is the second part of the T wave. Actually, whether it is symmetrical or not, to consider it, we should increase the length. You see, when the length of the left edge is increased up to the same level, now we can see both the limbs are the symmetrical. So this is not the height, this is the symmetry of both the sides. This is the rising and declining parameter of the absolute, that is the first part and the second part of the tube, that defines the whether it is symmetrical or not. So this is the symmetrical tubes. We are confused with the V4, V5. These are not symmetrical, but these are the symmetrical tubes. So this is the special type of the hyperacute ischemia where the ST depression is downsloping with a, that is the concavity upwards ST depression, and this is the special variety, that is D Winters T wave. First of all, this is the hyperacute T wave, that is hyper tall peak T wave because of the hyperacute ischemia, and this is the special variety because of the D Winters T wave. So now the T inversions. There are some causes of the T inversion, that is the abnormal T inversion, that is the causes of the T inversion, the abnormal conduction, strain, ischemia, and chronic pericarditis. These are the causes of the T inversion. And the types of the T inversion are the primary T inversion, that is the primary problem of the repolarization. When the T inversion is because of the primary problem of the repolarization, it is called the primary T inversion. And when the T inversion is because secondary to the abnormal depolarization, as for example, in case of the bundle branch block, LVs, permanent pacemaker, or pre-excitation, these are called the secondary T inversion. So T inversion, these are the causes of the T inversion, and there are two types of the T inversion. This is one of the example. This is the, in case of the bundle branch block, particularly the late bundle branch block, the T wave should be discordant. The physiologically what we have learned, that is T wave should be concordant with the QRS complex. But in case of the bundle branch block or conduction abnormality, the T wave should be discordant. That is the QRS complex going upwards and the T wave is going downward. This is the normal in case of the, this is normal for the bundle branch. This T wave movement is normal for the bundle branch block. That is T wave is going opposite direction of the QRS complex. Like this is the T depression, and this is the T, that is the upright T wave. But when the pathology happens, as for example, acute ischemia, in such cases, that is in presence of the bundle branch block or pacemaker, then what happens? That is the exaggeration of the normal physiology. Exaggeration of the normal physiology. That is, the T wave will move in the same direction. That is the concordance. Instead of the discordance, the T wave will move the concordance or excessive discordance, either concordance or excessive discordance or STD. This is the Garbosai criteria. I am not going to describe this criteria, but this is what happens in case of the physiology in presence of the bundle branch block, that is discordance T waves, and in pathology in presence of the bundle branch block, discordance T wave. This is the actually message from this ECG. So this is one of the example. This is the case of the late bundle branch block. You can see this is clearly a ECG of the late bundle branch block and discordant T wave. That is the predominant QRS complex going downwards and T wave is going upward. This is against the normal physiology, but this is the normal physiology for the bundle branch block. The discordant T wave. This is the in case of the late bundle branch block, and this is the secondary T wave synthesis. In case of the right bundle branch block, the T wave is going in opposite direction, that is discordance. This is physiological, and this is the secondary T wave synthesis. And this is the again T wave synthesis, ST depression and T waves going in opposite direction, that is discordance. And if you can see the company it keeps, there will be the short PR interval and the delta wave, that is the delta wave and the short PR. This is the delta wave and the short PR interval. So this is obviously case of the pre-excitation, and this is also a conduction abnormality and discordance T wave. So this is secondary T wave changes, that is secondary to the depolarization, what happens in case of the pre-excitation. So another example is the biphasic T wave. There are the two types of the biphasic T wave. The biphasic T wave, two types of the biphasic. That is, the first part is positive, second part is negative. This is the biphasic T wave like this. Or first part is negative, second part is positive like this. So this is fits in case of the acute ischemia, and this is characteristics of the hypokalemia. So biphasic T waves, there are two causes, acute ischemia or the hypokalemia. Positive followed by negative ischemia, negative followed by positive in case of the hypokalemia. So this is the example. This is one of the example of ECG. You can see this is the biphasic T wave. You can see in the particular in case of the V2, V3, V4, V5, V3, it is very much clear. That is first part is positive followed by the negative, positive followed by the negative. So this fits the ischemic criteria. So this is the this biphasic T wave is because of the acute ischemia, and company it keeps, that is the R wave is preserved. There is the normal progression of the R wave from the V1 to V6. That is the R wave progression is normal, and this type of finding even may be present in the pain-free period, and the cardiac enzyme may be normal. So this is an example of the acute ischemia, and particularly with or without presence of the chest pain or angina, either it can be acute coronary syndrome, or particularly it can fulfill the criteria of the OLN signs. OLN signs. When this criteria fulfilled, that is the preserved R wave progression may be present in case of the pain-free period or normal cardiac enzyme. Then it is a special variety, that is OLN syndrome. Otherwise, this is acute coronary syndrome. So this is OLN syndrome is a special type of the acute coronary syndrome when this criteria fulfills. So this is the ischemic type of the biphasic T wave. This is the main message. That is ischemic type of the T wave changes. That is positive followed by the negative. This is another example of the T wave changes. Here the T wave changes is, that is the T wave. The T wave is, that is the flat, that is the, it is the some deformity of the T wave. That is the like this. That is the long T wave. There is the some spoon shape, that is the going downward. So this is a special type of the T wave. This is not like this normal T wave. So this kind of the T wave, this is also present in globally, that is in almost all the ECG, that is the leads, it is present. So this is a special type of the T wave inversion. The first part is negative, you can see in the V4, that is the first part is negative followed by the positive. That is global in distribution, that is in all the leads it is present. Negative followed by positive, global in distribution, and QT is prolonged. QT is definitely prolonged in this is. So company it keeps suggest this is due to the hypokalemia, and company it keeps also strongly suggests this can be due to the hypokalemia. So hypokalemia is one of the causes of the T inversion, and this is the characteristic of the T inversion case of the hypokalemia. That is negative followed by positive, negative followed by positive, global and prolonged QT interval at the company it keeps. So this is the so this is another example of the pacing ECG. So there will be some that is the T wave changes, and again this T wave changes like the preceding ECG. So this pacing ECG should always produce the, that is the discordant T wave, and these discordant T waves is also accompanied by the prolonged QT interval. So this pacemaker patient has got some abnormalities of the potassium also, that is the hypokalemia. So this is a paced rhythm in presence of the hypokalemia producing such type of the T wave changes in case of the so another is the ischemic T inversion. The ischemic T inversion, there are two causes of the ischemic T inversion, either the subendocardial ischemia or the transmural ischemia. Subendocardial or transmural. In case of the subendocardial ischemia, there will be the exaggeration of the normal physiology. Exaggeration of the normal physiology. There will be ST depression, and the T wave will be tall. But in case of the transmural ischemia, the T wave will be inverted, symmetrical, and pointed. So this is the transmural ischemia. This is one of the example. Here you can see this is the T wave is inverted, pointed and symmetrical. This is that this limb is longer and this limb is shorter, but these are the symmetrical. If you can increase the length, so the left part and the right part will be the similar. So this is the symmetrical. That is symmetrically deep pointed T wave inversion is a criteria of the transmural ischemia. So this is one of the example of the transmural ischemia. This is another example of the T wave inversion where the T wave is pointed deep. So this is the T wave inversion. So here also the company it keeps follows the that is that there is some criteria of the LVH, the left ventricular hypertrophy. This T wave inversion is also accompanied by the some criteria of the left ventricular hypertrophy, and there is no T inversion in case of the V5, that is V1, that should be negative, but here it is positive. So this is the T wave inversion in presence of the left ventricular hypertrophy, and the differential diagnosis of the left ventricular hypertrophy, cardiomyopathy, acute ischemia, metabolic cause, cerebrovascular accident, and some drug brigade, particularly the tricyclic antidepressant. But this is characteristic of the left ventricular hypertrophy in presence of the hypertrophic cardiomyopathy. So basically, this is the it follows the criteria of the hypertrophy, that is the hypertrophy, and these are the differential diagnosis. And most of the time, this is the left ventricular hypertrophy or the acute that is the hypertrophic cardiomyopathy. But it should not be the acute ischemia. Acute ischemia can be excluded as because the T waves are symmetrical. If you can draw this line, the T wave is symmetrical. So presence of the symmetrical T wave inversion excludes the. So this is the way by which we can differentiate it from the acute ischemia. So this is the deep T wave inversion, particularly present in case of the left ventricular hypertrophy or the hypertrophic cardiomyopathy. This is another example when such type of the T wave inversion presents in presence of the LVS criteria. There will be downsloping ST depression. This is the downsloping ST depression, particularly deep T inversion. This is called the strain pattern. So strain pattern means LVS plus this criteria, that is presence of the LVS criteria and downsloping ST depression plus deep T inversion. When LVS criteria is associated with these criteria, this ST depression criteria and the T inversion, then this will be the strain criteria. So this is the left ventricular hypertrophy with strain, either because of the left ventricular hypertrophy, some other causes, or particularly or from the hypertrophic cardiomyopathy. So this is the actually left ventricular hypertrophy with strain pattern. So the T wave inversion is deep, pointed, without with or without the strain criteria. This is another example. This is the bifid P wave. Bifid P wave. You can see there is a two humps of the T wave. Two humps of the T wave. These are the particularly in case of the second degree AV block or non-contacted P waves, when this P wave actually positioned over the some parts of the T wave, then it produces this such type of the T wave. So this is called the bifid T wave. This is one of the example of the that is the bifid T wave because of the secondary, that is the second degree AV block. This is another example of the T wave. When the T wave are present, that is the T inversion, that is the T waves are inverted here. That is V4, V5, V6, and some other leads lead 1. But these are less than 3 millimeter. When the T wave is present less than 3 millimeter in height and does not fulfill the other criteria by the company it keeps, as for example, there is no other criteria to define the company it keeps, that is this T wave, then these are called the non-specific T wave. So less than 3 millimeter T inversion without any other criteria to define it, then it is called the non-specific T wave changes. So this is also one of the T wave changes. And this is another example of the T wave changes when the T waves are very much difficult to define. These are the T waves at the flat. This can be the position of the T wave. This can be the position of the T waves, but the T waves at the flat. So this is called the flat T waves. This is also one kind of the abnormality of the T waves. And another abnormality of the T waves is the NTTW-V1, that is new tall T wave in V1. This is one of the abnormalities of the T wave. That is, T wave is physiologically negative in V1, but here the T wave is positive in V1. The tall T wave in V1 may be normal, left ventricular hypertrophy, bundle branch block, or acute coronary syndrome. But when this type of the T wave is present with the symptoms of the acute coronary syndrome, then it suggests the coronary artery disease. That is, new tall T wave in V1 plus angina, coronary disease, or tall T wave in V1 is greater than V6. That is, the amplitude of the T wave should not be greater than the amplitude of the V6 of T wave. So when the T wave amplitude is V1 is greater than that of the T wave in V6, this is called the tall T wave. V in V1 is greater than the tall T wave in V6. This is also such as the coronary disease, and particularly LED disease. But these all should be in presence of the symptoms of the acute coronary syndrome, in presence of the syndrome. Otherwise, this can be, this type of the T wave may be normal, LVS, bundle branch block. But when it present with the symptoms, then these are the very much important. So there is another types of the T wave abnormalities, that is the T wave alternance. You can see this is the amplitude of the T wave, this is the amplitude of the T wave, this is the amplitude of the T wave. There is bit to bit alteration of the T wave amplitude, and that indicates the bit to bit dispersion of the repolarization of the myocardium. And this is one of the arrhythmogenic factor and is many times related with the sudden cardiac death. So this is another example of the T wave abnormalities. So finally, the take-home message is that there are several types of the T wave abnormalities, particularly the tall T waves, either because of the hyperkalemia or hyperacute ischemia, or biphasic T wave, again hyperkalemia or hyperacute ischemia, that is the hypokalemia, or bifid T wave because of the second degree AV block, or inverted T wave with either ischemia or secondary changes. And these are the different varieties of the common varieties of the T wave senses, and some other rare varieties of the T wave senses, that is the non-specific T wave, flat T waves, T wave alternates, D Winters T wave, or the Whelan's T wave. And T wave interpretation is very much important, but always it must include the clinical data, company it keeps, and we should remember the T wave sense is not always ischemic. There are some other causes other than the ischemia. And finally, this is the main message, is that T wave ECG is very much important and considered as the underdog in ECG. T wave is the underdog in the ECG for interpretation. Thank you very much for your patience hearing.
Thank you, Atahar bhai.
I think this is a very nice review. I'm Dr. Aziz Haq. And you're right on that, T wave abnormality, we always have to keep in context of the clinical picture. Any dynamic T wave changes, you have to be very careful if any dynamic T wave changes. And always, if you have compared with the previous ECG and also compare with the clinical context, that's a very important point. Second point I'd like to make, that it's always confusing. That's for the trainees. I'm just, when you look at the axis of the T wave, we understand that the depolarization starts from the endocardial area. It moves to the more epicardial area. Okay, that's the direction of the depolarization wave. But the depolarization we see in normal condition, it starts from the epicardial area, goes down, goes towards the endocardial area. So that's maybe it's confusing to understand that, because we might theoretically think about, okay, why is the depolarization starts after the depolarization will start after that. So it should theoretically should begin from the endocardium going to the epicardium, but it does happen in the opposite way actually. The main reason that I think that Rafiq bhai can also attribute, or Atahar bhai can attribute to that, main reason probably because of the circulation that we have, epicardial artery is bigger in the epicardium. The circulation, blood flow is bigger in the epicardial area. That's why those cells have better access to the electrolytes, quickly equilibrate the membrane of the cells and can repolarize quicker. And that's the reason we see in normal condition, the repolarization happens from the epicardium to the endocardial direction. I'm not sure, Dr. Rafiq Ahmed and Dr. Atahar Ali, you can just explain that a little bit, but that's my understanding of that. Because otherwise it's kind of confusing, because depolarization starts from the endocardium, then we think that maybe repolarization will start on the endocardium and go to the epicardium, but it doesn't happen that way. It happens the opposite way. Roy bhai, I know, or Atahar bhai.
No, I think you're right. I think going too deep into the mechanism will be beyond the scope of this talk today. And so I think we should continue with if there are
Okay.
any questions. If there are any questions, but I thought that was a very good talk. And but the interesting part, like anything in ECG, the dynamic nature is very important. That's one. Second, clinical picture. And of course, the other nitty-gritty of the ECG is that I always believe that if you keep looking at ECGs, then it's a pictogram. You suddenly look at a picture and recognize what it is, and then you exclude it. Thank you.
Adil bhai, M. Shafiq.
One comment I'll be making that you should be expecting the T wave should be negative in P1. If it is positive, there is something wrong. For example, in case of acute chest pain, and you are having obviously apparently normal ECG, but you get a very good T wave in V1, V2. That should not be there. Normally, V1, V2 gets very smallish T waves. And if it is there, look at R wave. You may get a tall R wave. Then do the posterior ECG, posterior leads, and you will find out you are actually dealing with a true posterior MI. That can happen. And we should remember that. And the second point is, as Sar was saying, in case of acute chest pain syndrome, look at the dynamism of the dynamic changes of the T waves. If it is there, the disease activity is there, it's an acute coronary syndrome, no doubt about it. You may not have a troponin immediately available, but still you can really start alerting the cath lab or taking proper precaution for thrombolysis or whatever, or anticoagulation as needed. That you can do.
I think, Dr. Although it's a very important point, because as we see that if you take like isolated T wave changes in non-ST elevation acute coronary syndrome, is 14 to 27% isolated T wave abnormality, 14 to 27%. And if you look at that T wave inversion that we normally see, or biphasic or T wave inversion, the reason troponin might not be elevated, because as they studied, I think I remember one article from 2018, they compared that the different kind of ST and T wave changes and the outcome of these patients, what kind of disease they have, mortality, and they have in 6 months and a year. And looks like the T wave inversion was the most significant one to correlate for, significant of coronary artery disease and mortality. And the reason that initially might not find like troponin elevation, because initial phase of T wave inversion relates to myocardial edema, not injury yet, myocardial edema. And that has been shown in a very nice article in 2018 by MRI, cardiac MRI. They looked at that myocardial edema is present when the T wave inversion in acute ischemia happens. And later phase, they go to injury pattern. So the myocardial edema is very important because that is a precursor for myocardial injury, necrosis for the future. So that's why T wave inversion is very important clinically. If you see that, and particularly the dynamic T wave that you mentioned, to be more alert, we need to be more alert on that there's definitely some coronary artery disease going on, and dynamic in nature, because sometimes stuttering, blood flow back and forth going on in that direction.